La próxima presentación, titulada Late Onset MS, What Real World Evidence Teach Us, está a cargo del Dr. Jefferson Becker. Jefferson es neurólogo de la Facultad de Medicina e Instituto de Neurología de la Universidad Pontificia Católica de Río Grande do Sul, en Brasil. Esta es la primera vez que contamos con la presentación del doctor en nuestro simposio Real World Evidence, así que va a ser realmente mucha expectativa escucharlo a Jefferson mostrando la evidencia en nuestro simposio. Adelante, Jefferson.
Hi, it's an honor for me to be here in this virtual symposium to talk about late onset MS, what real-world evidence teaches. I'd like to thank the organized committee for this kind invitation. And these are my disclosures. And the way they prepare this lecture is reviewing a bit about late onset MS, explaining the difference shortly about randomized clinical trials and real-world data, real-world evidence, and showing the data that we have in LOMS, late onset MS, and in the end, review some important aspects. So the aim of this lecture is to show that we can indeed have important information from this real-world evidence in late onset MS. So let's briefly review some aspects of late onset MS. First, it is defined as those patients that start with the disease after the age of 50 years. And also they include some patients that have a very late onset MS, that are those patients that start with the disease after the age of 60. It's important to consider that some others believe that the cutoff should be 40 years, but most of the authors consider the cutoff of 50. And it represents something in between 1 to 10% of the entire MS patients, but it can reach more than 20% if we consider a lower cutoff of 40. But overall, the majority of the papers reach some numbers in between 3 to 5%. And a recent meta-analysis showed reached a number of 5% of LOMS in the total MS case. And if we consider the VLOMS, the very late onset MS, it's usually somewhere in between 20% of the late onset MS. So it would be around 1% of the total MS population. It's slightly more common in males, but it is more common in females as in MS overall. So it represents something from 1.4 to 1.7 in some papers. But we have in some cohorts a higher female predominance than what we found in a Brazilian cohort, that we found 2.1 to 1 male to female. And it's important to consider that the incidence of LOMS is increasing, mostly among women. And also it's very important to say that in the elderly population, there is a progressive weakening of both adaptive and innate immune system that we call immunosenescence. And I will return to this later on. Another important aspect is the differential diagnosis. And we must include vascular disease and cervical spondylotic myelopathy, because it has a higher prevalence in this age and many times similar symptoms. But the problem is that in the elderly population, these vascular risk factors like hypertension and diabetes are much more common, and it may get a bit challenged to differentiate some findings due to ischemia or to demyelination. Even in the MRI lesions. So in some papers, there may be a delay in the diagnosis that reach almost 5 years in almost 40% of LUMS patients. Although there are some papers that say that this does not happen, that can even, the diagnosis may be done even earlier. But the majority consider that we may have a delay in the diagnosis. But how do patients present? Most patients with LUMS has a monosymptomatic presentation, mainly with a motor or cerebellar symptom, have a higher EDSS from the beginning of the disease, and a higher probability of the start of the disease with a primary progressive MS. Moreover, more patients present with the primary progressive MS when we compare with the non-LUMS age groups. But relapsing remitting MS is still the most common presentation in most series. In that meta-analysis, they found that 50% of the patients start with relapsing remitting MS. But it's clear that if we compare over the age, over the years, we found a higher increasing of primary MS people, mainly in these patients above 50 years of age. But in the majority of the papers, relapsing remitting MS is still more common in LUMS patient. And just in very late onset MS, the progressive MS is definitely more common. But an important aspect, an important question is it really late onset? What they found in this interesting paper is that some patients, if you carefully question these patients, they found a prior relapse in these patients. So many of these CIS or primary progressive patients were reclassified as clinically defined relapsing remitting MS or secondary progressive MS. So they found that over 40% of the primary progressive MS or a third of the CIS patients have already had a prior relapse. So they were reclassified later on. Most of the patients have spinal cord involvement, about 2/3 of the patients, which is in keeping with the finding of more common progressive MS. And the majority of the patients present with the motor symptoms followed by sensory, brainstem, or visual symptoms in the beginning of the disease. And the proportion of oligoclonal bands or IgG index is roughly the same that we found in adult onset MS. Another important aspect is that these patients have a worse prognosis in terms of disability, and they reach the higher EDSS in a short period of time. So it's clear here that we see that patients with late onset MS reach a higher EDSS much earlier than we found in adult onset MS or in younger patients. And this is common in the majority of the papers. In all of them, we found that these patients reach higher disability much earlier than adult onset MS or pediatric onset MS. So after a 5-year follow-up, the majority of the patients have some ambulation impairment. Some of them are actually confined to wheelchair. And if you consider the neurologic examination, most of the patients have abnormal examination due to relapse or progressive deficits. But if you consider the age that the patients reach this higher EDSS, we're going to see that although they reach it in a shorter period of time, the other patients reach higher EDSS much younger. And it's even clear in this paper. Okay, again, this late onset MS reached a higher EDSS in a shorter period of time. But if you consider the age of these patients, they are going to reach it much older than what happened in patients with a pediatric onset MS or adult onset MS. But why does this happen? MRI may help us to clarify why this happens. So if you consider T1 and T2 lesion volume, there is no difference between LOMS and adult onset MS. But if you consider the ratio T1 over T2, it's going to be higher in later onset MS. And this might indicate that there is a greater axonopathy in late onset MS. Moreover, brain parenchyma fraction was significantly lower in late onset MS. And this again indicates that there is a more pronounced neurodegenerative process. And you must also consider that the brain plasticity is less effective in LOMS in comparison to adult onset MS. Finally, gray matter fraction is significantly lower in these patients with late onset MS, but it does not happen in white matter fraction. So again, it indicates that gray matter atrophy is much more pronounced in late onset MS. So putting this together, we can say that the process in late onset MS is more destructive and have a more predominant axonal damage. So let's move forward and compare a bit of randomized clinical trials and the evidence that we have in the real world data and real world evidence. And here we have a problem. All the licensed drugs that we have been studied in clinical trials that usually recruit patients up to 50 or at most 55 years of age. So the vast majority of the patients with late onset MS were not adequately studied in relation to the DMDs. So randomized clinical trials are treated under ideal and controlled conditions. But this is not real. When we have a patient in front of us, we have much more heterogeneous aspects that are not really studied with the randomized clinical trials. So the medication behavior, even patient monitoring are not in the protocols most of the time. The stratification, the treatment sequence, the outcome definitions and monitoring, the selection of the treatments, these are not feasible with the randomized clinical trials. And also we have some restrictions on age, disease type, comorbidities, treatment environment, and many other aspects. And finally, the duration of the randomized clinical trials are much shorter, so we cannot evaluate adequately long-term risks and benefits of the therapies. Real-world evidence, on the other hand, can complement this data generated in clinical trials. So they can investigate in a more diverse group of patients, and they can generalize the information across the populations with MS that are treated or monitored according to this standard clinical practice. And most of the times they are observational in nature and can collect the data during a routine clinic or retrospectively with big databases. So let's move forward to the pivotal clinical trials in late onset MS. And actually, these randomized clinical trials were not designed to assess efficacy in aged patients. And they excluded these patients in many of these trials. If you consider the trials with glatiramer acetate, interferon beta-1b, natalizumab, or alemtuzumab, they did not include patients older than 50 years. And interferon beta-1a, dimethyl fumarate, fingolimod, reflunomide, rituximab, ocrelizumab, and ozanimod, they include patients until 55 years of age. But we do have some data of the response of treatments with these drugs in late onset MS, and they are mostly based on real world evidence. But we do have a recent meta-analysis with 38 randomized clinical trials that found that after the age of 53, there was no benefit of this treatment in MS. I took this picture last July in Buenos Aires. So I think it's important to analyze this. It's roughly the same if I say that I'm gonna order a salad, and I say with this picture here that the tomatoes are not good, or that the onions here are not good as well. What I'm trying to say is that this model is wrong because it was based in those clinical trials that clearly underpowered patients older than 50 years. And sometimes they just did not include these patients. Moreover, it was based in patients' mean outcomes, but the idea was to consider individual patients' outcomes. So it's reasonable that we can hypothesize that among late onset MS, there are some patients that can respond to DMTs. And we have a post hoc analysis of the Clarity trial that include patients up to 65 years that they found that the response, the drug was similarly effective in younger and in comparison with older patients, although they used the cutoff of 40 years of age. So what do we have of real-world data or real-world evidence in late onset MS? We have this very interesting paper that they compared disease-modifying drugs in pediatric onset MS, adult onset MS, and late onset MS. And what they found is that DMD decreased the risk of disability accumulation in all groups, but it did show a smaller response in those patients with late onset MS. They still find the response, but a bit smaller than in the other groups. This other paper here, also of an Italian registry, they compared the response of patients that used the injectable drugs and compared with the oral groups. And what they found is that there was a similar response in the risk of relapse, CDP, and treatment discontinuation. And we clearly know that the oral drugs are usually more effective than injectable ones, but it was not found in this paper. And they say that this may be due to immunosenescence that may reduce the response of these drugs. But can we treat these patients? How can we use DMDs in late onset MS? And the decision to initiate a DMD in the elderly patients should be carefully considered due to the risk factors associated with therapy and to a smaller efficacy. But we should use the same algorithms that we use in younger people, mainly because we don't have a specific algorithm to these patients. And regardless of the age, if the patient have an inflammatory activity, we must treat them right from the beginning and should continuate the immunomodulatory treatment. However, obviously, we must consider that these patients have a greater risk of infection or neoplastic complications, so we must introduce these drugs with more caution. But what we found really most of the time is that these patients are less treated than the other patients. Obviously, you must consider that we have a higher amount of progressive MS patients, primary or secondary progressive, in that in many countries, the drugs for these patients are just not available. And what we see in real-world evidence in MS, I'm going to take this paper here just to show what we found in adult onset MS. And what they found in this paper is that the response of these drugs after the clinical trial was roughly the same what was found in the trial. And Professor Comey recently reviewed newly approved drugs, fingolimod, teriflunomide, methylfumarate, alemtuzumab, and ocrelizumab, and compared the findings of these observational studies with randomized clinical trials. And what they found is that the effect of normalized relapse rate and MRI active lesions were even better than in comparison to randomized clinical trials. Moreover, they found more adverse events, new adverse events that was not found in the randomized clinical trials due to the smaller amount of patients and to a shorter period of time. So they can definitely add some new information. But we don't have many papers in LOMS talking about DMDs. But there is this paper in teriflunomide, and they found that the teriflunomide the efficacy was demonstrated regardless of age. And safety was also consistent across age groups. And finally, these papers propose a very interesting methodology. What they propose that we should use randomized clinical trials and real-world evidence studies joined together, combined in a Bayesian network meta-analysis. And doing this and planning this together even earlier, previous the phase 3 trials, could reduce the sample size of pivotal phase 3 trials and save time and obviously money. So this could be a very good way to deal with these patients with late onset MS, mainly because we have much less patients in this group of MS. So what it should take home message. Firstly, the definition, we include patients with a older than 50 years, and it represents around 5% of total MS case. The incidence of LOMS is increasing, and most of the patients have a monosymptomatic with a motor or cerebellar symptoms, higher DSS, and a higher probability of starting disease with PPMS. Around 2/3 of the patients have spinal cord involvement, and it has been associated with a worse prognosis with a short period of time, possibly due to a more dominant axonal damage. Moreover, we have very few studies that included these patients. Actually, most of the DMTs did not include these patients or just a small amount of the patients analyzed. And in the real world evidence, they confirmed that these DMDs were effective, although a bit lower effective. And the magnitude of effects on annualized relapse rate and MRI active lesions were still detectable in these observational studies compared to randomized clinical trials. So with this, I finish my talk. I'll be happy to answer some questions. Thank you very much.
Jefferson, felicitaciones. La verdad que excelente presentación, muy buena revisión de lo que es la literatura en un tema muy complejo. Y yo quiero arrancar esta ronda de preguntas con una pregunta relacionada en lo que es el tratamiento. Mostraste algo epidemiológico y de la fisiopatología en donde en late onset predomina el componente de progresión, la axonopatía, no hay tanta inflamación en el sentido de que no vemos tanta recaída, no vemos tanta lesión focal en la resonancia. Y mi pregunta va relacionada si eso nos tiene que determinar la selección del tratamiento. Cuando vemos un late onset, tenemos que considerar esos datos para seleccionar un tratamiento. Es decir, si debiéramos tomar esos datos epidemiológicos para seleccionar tratamientos que vayan más hacia ese componente progresivo y dejar de lado por ahí esos tratamientos que desde la evidencia mostraron que iban más hacia el componente inflamatorio. ¿Debiéramos reposicionar la selección de los tratamientos basados en esos datos en la práctica clínica?
Sí, yo creo que sí. Claro que tenemos que mirar al paciente que está enfrente de nosotros, ¿no? Y si él tiene una carga lesional muy alta con mucha inflamación, tenemos que tratar como si fuera un tratamiento con alta actividad, ¿no? Sí, pero en la mayoría de los pacientes, yo creo que los tratamientos para progresión son los más importantes acá y tenemos que mirar esto. Porque esos pacientes van a atingir, ¿sí? Más progresión más temprano. Entonces no podemos perder tiempo con esto.
Está claro.
Porque más temprano tenemos que iniciar tratamientos para progresión. ¿Sí?
Clarísimo.
Sí, y nuevamente yo también te quería felicitar, Jefferson, por la claridad de tu presentación. Y mi pregunta tiene que ver con esto. En pacientes con late onset MS tenemos una mayor prevalencia de comorbilidades. Hay diabetes, hay hipertensión, por ejemplo. Está el fenómeno de inmunosenescencia, en donde tal vez probablemente eso ejerza una influencia en la respuesta a las drogas. Considerando estos factores, ¿eso podrá influenciar de alguna manera nuestra decisión en seleccionar el fármaco y tal vez preferimos iniciar con drogas más seguras, aún no tan efectivas, para tratar de minimizar los eventuales riesgos, considerando que son pacientes más añosos, por decirlo de alguna manera? ¿O eso no debería influenciar nuestra decisión?
Yo creo que esa es una pregunta muy interesante, pero muy difícil. La verdad es que como estos pacientes no son estudiados, ¿sí? Tenemos muy poca información. Yo no sé decir si podemos empezar con esta droga o otra droga, ¿sí? Pero lo que vimos con otras medicaciones, no hay un problema muy grande con si el paciente tiene hipertensión o si tiene diabetes. No parece que es un problema grande, ¿sí?
Okay. Sí.
yo personalmente creo que nosotros tenemos que ser más agresivos siempre en todos los pacientes. No importa si es adult onset MS o late onset MS. ¿Sí?
Sí, sí.
Entonces, específicamente en este grupo de pacientes que van se quedar mal probablemente en un corto periodo de tiempo, yo creo que tenemos que ser más asertivos, ¿sí? Empezar con el mejor tratamiento lo más temprano posible.
Exacto.
Pero no tengo certeza si tenemos información suficiente para esto, ¿sí?
Está claro. Jefferson, yo quería una más relacionada con las medidas de resultado, porque cuando vemos por ahí muchos de los resultados que dicen que no funcionan los medicamentos en estos pacientes.
Para un
Sí,
poquito.
sí, sí, claro. Sí, sí.
Solo un rato,
No.
por favor.
Sí, no. Si querés frenamos la grabación.
Sí, sí, no hay problema.
Después los chicos la editan. No
Sí,
te
sí.
preocupes,
Sí,
Juan.
los chicos la van a editar.
Sí.
Pero
Sí.
justo que venías embalado, Juan, no te olvides.
Sí. Jefferson, ¿ya estamos? ¿Querés? Bueno, ahí está. Jefferson,
Sí,
quería...
pregúntame.
vamos. Jefferson, quería preguntarte o conocer tu opinión relacionada. Uno muchas veces ve que se hacen comentarios en relación a que las intervenciones, los medicamentos no funcionan en estos grupos etarios, pero cuando se ve o se ven basados en qué tiene que ver con que no han funcionado en recaídas y lesiones focales en la resonancia. Y está claro que en este grupo de pacientes, a estas edades, ya las recaídas y las lesiones focales en la resonancia empiezan a disminuir y probablemente no veamos. Mi pregunta específica es, ¿qué medidas de resultado crees que debemos aplicar para las intervenciones, para los medicamentos, para ver si funcionan o no en este grupo de pacientes? Probablemente tengamos que ir por otro lado, por otras medidas de resultado para saber si los medicamentos funcionan o no y efectivamente decir si funcionan o no. Es decir, debamos emplearlas en intervenciones, estudios observacionales, ensayos clínicos, específicamente por dónde crees que debamos ir para saber si funcionan o no los medicamentos en este grupo etario.
Claro. Primeramente, yo creo que tenemos que hacer más estudios, ¿sí? Porque, como ya he intentado mostrar con los vegetales, ¿sí? La verdad es que no los estudiamos, entonces no sabemos, ¿sí? Tenemos que pegar solo las cebollas, los tomates y mira, ¿qué pasa aquí específicamente? ¿Sí? Yo creo que la respuesta existe, ¿sí? Puede ser un poco menor, pero está allá, ¿sí? Y claro, tenemos más pacientes con progresión. Y esto es un problema en todos los pacientes, si son más jóvenes o no, es un problema. Entonces, tenemos que incluir los datos de resonancia, de brotes y de progresión, y separar distintamente. Los pacientes son más viejos, sí, pero tienen una enfermedad con más inflamación. Entonces, para estos, tenemos que mirar la resonancia, los surtos, los brotes, y, en fin. Pero para los otros que tienen una enfermedad más progresiva, para eso tenemos que mirar aspectos de resonancia o que sea. Entonces yo creo que tenemos que estudiar más estos. Y para esto, real world data es probablemente lo mejor que podemos hacer más rápidamente para tener estas informaciones. Pero yo creo honestamente que podemos hacer lo mismo, pero separando estos pacientes. ¿Sí? No sé si me quedé claro, ¿no?
Coincido, sí, sí, sí. No, clarísimo,
Sí.
clarísimo, clarísimo. Lili, ¿alguna pregunta extra para Jefferson?
Una última pregunta para él. Obviamente, y considerando que los datos son sumamente escasos, En estos pacientes con un comienzo tan tardío de la enfermedad y en el eventual caso de que iniciemos una terapia, ¿en qué momento podríamos o deberíamos considerar suspenderla, discontinuarla?
Es un problema, ¿no? Yo tampoco tengo una respuesta para esto.
Sí,
Pero te voy a retornar con algo que se pasó con un paciente de nosotros. Ahora, es en agosto, ¿sí? Un señor con 70 años de edad que estaba claramente evolucionando, ¿sí? Para una esclerosis múltiple secundariamente progresiva, ¿sí? Hacía muchos años que estaba sin brotes, ¿sí? Y evolucionando para un cuadro claramente secundariamente progresivo, ¿sí? Entonces, junto con el paciente, decidimos parar con el fingolimod. De hecho, estaba usando fingolimod. Y paramos la medicación y como menos de 6 meses después ha hecho un brote medular. Entonces, yo aún tengo muchas restricciones de cuándo parar, porque la verdad que no lo sabemos en cuál paciente que van a hacer brotes, y para estos pacientes, esto pequeño brote, si queda con una incapacidad a más, puede ser terrible, ¿no?
Sí, 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 sí.
Está claro, está claro, está claro. Bueno, Jefferson, muchísimas gracias. La verdad que muy clara, muy buena la revisión y la presentación. De mi parte, no tengo más que agradecerte. No sé, Lili, si tenés algo extra de preguntas.
No, agradecerte muchísimo, sobre todo porque nos has generado muchísimas inquietudes sobre un tema en el que tenemos tantísimo trabajo para hacer y para tratar de dar respuesta a muchos de estos interrogantes que tenemos. Así que nos has abierto la cabeza como para trabajar muchísimo en todos estos aspectos.
Tal cual. Y nada mejor que real world data y real world evidence para este punto en donde los ensayos clínicos es muy poco probable de que lo cubran. Gracias, Jefferson.
Sí, muchas gracias por la invitación y por poder estar con vosotros, aunque distante. Muchas gracias.